Hello, everyone, and welcome to the Down Syndrome Center of Western Pennsylvania podcast. As you all know, I'm your host, Dr. Kishore Velody, and also, as you all know, we have a wonderful friend of the podcast who's a pediatric infectious disease specialist named Dr. Andrew Nowalk. Andy, thank you so much for coming on board again with us today.
Kishore, the invitation is always welcome. I'm always glad to come and talk to my folks in the Down syndrome community.
I love it. I love it. And, as our listeners know, if you've listened to any of our prior COVID podcasts, not only is Dr. Nowalk a infectious disease expert in pediatrics, but also a father to a wonderful young man with Down syndrome. So he comes at it from so many different angles. And so we really do appreciate you sharing your expertise because, as always, yet again, you get an email from me with a couple of exclamation points saying, oh my gosh, there's this new article. And a lot of emails have come in to the center as well as to some national organizations. And so people reached out to me saying, hey, can we get this Dr. Nowalk's thoughts on these articles? But before we get there, I was hoping, Andy, you might be able to just give us any updates in terms of COVID in general as it relates to pediatrics, but really specifically focusing on ways that we can reduce the spread as we're seeing rises all over the country.
Well, Kishore, I think we are, every time we have talked about COVID on this podcast, and I think it's been useful to talk about it over time. I hope that folks who have listened have appreciated that we learn more every time. And so our base of knowledge has grown quite a bit. First and foremost, we've learned some simple things that have been proven over and over and over again. And the main one is really when everyone is masked, everyone is safe. And when we choose not to mask, we choose to put people at risk around us. We've seen that frequently. And I think that outside of, the early part of the epidemic where folks were so quarantined that transmission happened in some very different ways, now I think we see that when we see clusters of infection, they are almost inevitably caused by people being near each other, gathered in certain settings where they are not masked. And someone who is sick, typically, not someone who is pre-symptomatic, but someone who is ill mildly, spreads a lot of disease in a short period of time. So we know now that masking keeps everyone safe, especially when the person who's sick is masked. We know that distance and time make a big difference, and that the farther away you are and the less time you spend near someone, the more your risk is reduced. We know that ventilation makes a big difference, that if you're in a closed space with poor ventilation, you're more at risk than if you're outside. And we certainly know that simple things like being cautious if you have any sick symptoms do a great job at protecting everybody. So we've learned a lot there, and we've learned that masks are probably our key intervention among everything I just talked about in preventing disease. We even have a little bit of very tantalizing information that is not quite confirmed yet that suggests if you wore a mask and you did get sick, you get much less severe infection. And there's a strong theory out there that the reason that we are seeing less severity with a lot more cases, number one, is we're finally getting better testing capacity. The US is doing about more than 1 million tests a day. We need to get up to about 10, but we're doing better. But the other thing is, our death rates have fallen dramatically as a proportion of the cases that we're seeing. And we think that's due to better care and, in many cases, less severe initial infections. And masks may have something to do with that. So that's point number one, we've learned. Point number two that we've learned is that the vaccines are coming. They're almost here, believe it or not. We probably need another month or two. But I think when we start 2021, we will be starting 2021 with a discussion of how to distribute a couple of vaccines rather than how to test a couple of vaccines. So in the United States, there are multiple vaccines being tested at the same time. There are 3 very large trials for 3 very different vaccines, and I expect all 3 vaccines will be effective. When I say effective, I don't expect any of these vaccines to be effective the way that your tetanus booster is. If you get a tetanus booster, you'll never get tetanus for the rest of your life. That's why it's such a great vaccine. Most of these vaccines will very likely be much more akin to a flu shot in that they will provide you pretty good protection against getting infected, and then they will provide you some protection against severe disease if you're infected. And that's really what we're expecting out of these vaccines. And that brings me to the third point. One of the things that's been talked about a lot now, as people start to throw their hands up in the air due to the epidemic, is, well, let's just let nature take its course. Let's do herd immunity. We have almost 10 million people in the United States who's been infected. If we can get that number up to 150 to 200 million, then we'll be fine. I hear that a lot. I hear that a lot from public officials. I don't hear that from any legitimate infectious disease doctor, pediatrician, internist, or any physician who has any good knowledge of this disease. If we infect 100 million people, we will cause the deaths of probably 1 to 2 million people at minimum. And then we'll cause a lot of other unanticipated deaths when our hospitals are so full that when your mother or your brother or your sister or your daughter or your son gets appendicitis, they will not be able to get into the hospital to have surgery to save their life. So when we talk about herd immunity callously, as if we will just solve that by letting everybody get infected, I just want to be completely blunt with you. Every legitimate infectious disease doctor in the world thinks that is one of the worst ideas we've had since the beginning of the pandemic. And let me tell you, we've had some bad ideas along the way in this pandemic. So I want to emphasize that.
Yeah. And I want to be totally clear. So you're saying herd immunity in the absence of a vaccine is impossible, and even not just a vaccine, but an effective and well-distributed vaccine is impossible. Would you agree with that statement?
Oh, no, it's possible. We can get there. It will cost millions of lives.
That's
and
right.
if you're, I have to say, there are some people around the world who callously have said, we're willing to spend 1 million lives and have a number of elderly people and immune-compromised people and people with disabilities pass away. What they don't recognize is how they will put perfectly healthy people at risk as well. Yeah. If we let everybody get infected with COVID in the next 4 weeks in the United States, there would be no hospital which would be able to have an emergency room open. It would be the greatest public health disaster in the history of our country. So and some folks may be listening and think that's a political point of view. It's not. It's actually just statistics. Mm-hmm. And it dictates the fact that herd immunity would be the wrong way to go.
So some things are possible, yet not advisable or perhaps moral when we're thinking about taking care of our population as a whole.
I think that's the perfect way to put it. Yes.
Wonderful. So, Andy, we've been talking a lot every time we've gathered, for this podcast, updates on these podcasts about COVID and in kids in general, but specifically, of course, kids with Down syndrome. Any updates that you know of that would be helpful for our listeners at this time?
I think what we continue to see is a very strong theme in pediatrics and COVID, in that we see very few children getting severe infections. We see very few children getting infections. So there's very clear data now to suggest that children, especially under the age of 5, seem to be relatively resistant to infection with COVID. And when they get disease, they get relatively benign disease. So we see in our communities tons of our adult hospitals filled with patients. And as you're familiar with at our hospital and pediatric facilities around the country, we see relatively few cases of pediatric COVID. So when we're talking about pediatric COVID, period, we're seeing very little. And for Down syndrome and children, the no news is good news paradigm holds here. We are just not hearing many cases of children with Down syndrome getting infected. It does not seem thus far the kids with Down syndrome seem to be getting infected more than other children who don't have Down syndrome. And I don't know that that'll hold forever. And we still need to get good data, because you hear me say this all the time. We need more data to be certain. But at least right now, talking to my friends in the ID community and talking to my friends in the Down syndrome community, we are just not seeing widespread disease in children with Down syndrome. So a small silver lining in what has been a very challenging 6 months.
I agree. And I think that's been a wonderful blessing so far for us to see. And I hope that can persist through the coming months. But one area that has been getting a little bit of press, and part of the reason why actually I wanted to go ahead and do this updated podcast with you, is looking at adults with Down syndrome. There have been a couple of studies that have come out, and one in particular very recently that came out. But before we get to that one, there was one that we looked at with Dr. Megan Freeman a few podcasts ago, was looking at the New York data when New York had the big outbreak, and they had put out in pre-publication status, this article, and then it's since been published in Genetics and Medicine. I was wondering, looking at the New York data, primarily out of Mount Sinai, but also another hospital that they added in now in their publication status. What are some things that you can take out of this article, out of Genetics and Medicine?
So I think that, if you look at this article, which you and I have been waiting to come out in final form for a while, we can draw some things about it that I think are pretty useful for folks to know. When we look at the number of people in a fairly large population of patients admitted to hospitals, and, in their study, they noted that they had about 7,000 patients admitted to their hospitals with COVID. They only reported 12 people with Down syndrome. And so if you are a bear of little brain, as I am, you would simply do a quick division. You would divide 7,000 by 12, and you would get a number around 500 to 600, closer to 600. So 1 in 600 sounds to me suspiciously like the number 1 in 800, which is our oft quoted prevalence of Down syndrome in live births in the United States, right? So 1 in 800. So that tells us, in general, if we were to make a really crude guess, it doesn't seem like there are a lot more people with Down syndrome in this study than there should be. So that's good. It seems like people with Down syndrome are getting sick along with people without Down syndrome, which is a comfort along the way. And when we look at the sorts of diseases that people with Down syndrome have, a number of them have dementia, and a number of them are in long-term care facilities. And so why that's important is what's emerged as one of the most important risk factors for adults to get severe COVID is being in a nursing home or a long-term care facility. And so the fact that a quarter of the people with Down syndrome in this study were from a long-term care facility, I think is a really important piece of the puzzle. It's a really important piece of the data that they present in terms of these folks. Beyond that, I think they show that people with Down syndrome can get very severe COVID. And that is not a surprise to you or I, knowing how severe pneumonia is in all ages of people who have Down syndrome. So that was not a surprise to me. What was comforting to me, and as much as you can get comfort from a study like this, is it did not seem to argue that the risks for people with Down syndrome were very different from the general population. That is, age and residence in a long-term care facility being the strongest predictors.
So one could almost say, and correct me if I'm wrong, but that adults with Down syndrome got COVID in this study at pretty much the expected number that we would see coming into a hospital setting. And those who get it, who have Down syndrome, tend to get it pretty significantly when they get it. Is that an accurate statement?
I think that's a completely accurate statement. Okay. Absolutely.
And so as we turn then to the Annals of Internal Medicine article that came out, which was a very large number of people included in this study, what were your thoughts? This was the one that we got quite a bit of emails over the weekend and over the last few days about. What are your thoughts about what this study, how it was set up and what it showed?
So this is an interesting study, Kishore, and you brought it to my attention, which was lovely. And then the next day, my automatic search on the PubMed site at the National Institutes of Health showed it to me too. So it confirmed that you are paying close attention, which I agree. I'm very grateful for. This is a different study. So Mount Sinai really chose to study people admitted to the hospital with COVID who had Down syndrome, and they gave us some lessons about that. This study is much more about a whole population look at who's getting sick with COVID inside and outside the hospital and who has Down syndrome. So I think that this is a fairly important study in that as a national study from the UK, it can give us some general population information. Very useful. The United States doesn't do well with this because we don't have a national health system that gathers data together. So we have to learn this often from other countries. And I think the UK is a good comparator. You have a relatively resource-rich country with a mixture of ethnicities similar to the United States and a range of poverty to wealth that is relatively within the range of the United States. So it's a good comparator for us in a lot of ways. When you look at the statistics from this study, I have to be completely honest. it really was reassuring to me in a lot of ways that people with Down syndrome, again, tend to look a lot like the general population in that the people who had COVID were folks who, in general, in the population were older. So if you look at the paper, the median age at death from COVID, the people who got severe disease who died from it were 60 years old in terms of the Down syndrome population and 80 years old in terms of the adult population without Down syndrome. And what that tells you is when you look at 60-year-olds with Down syndrome, they are at the far end of the curve. Our improvements in life expectancy with Down syndrome are really advancing, but the cohort that's going to live into their 80s is probably right now in their 30s and 40s. So I'm not surprised to see a lower age of death. A lot was made out of that, but I am not surprised to see that at all. The other thing that struck me dramatically in this is that the people with Down syndrome who got COVID in the study cohort were dramatically more likely than in the general population to be in a long-term care facility, in a residential or a nursing home. It was less than 1% of the general population. It was 16% of the Down syndrome population. So that is a lot. And what that says, again, is that people with Down syndrome who are older and in nursing homes are likely to get severe disease. So that's all I'm going to take from this study. I think it's not designed in a way that makes me think that you can say a person with Down syndrome is 10 times more likely to die from COVID. I think this tells you that if you are a person with Down syndrome and you're older and you are living in a long-term care facility, you have a high likelihood of a bad outcome from COVID, but it doesn't tell me that the risk is so dramatic that it's a tenfold risk. I think both of these studies point out some very important lessons. Number one, we have done a terrible job with long-term care facilities in protecting the people in them, period. This is a lesson, unfortunately, we've learned in every state that's had it and in every long-term care facility, in that when we get cases in the facilities, we often get huge outbreaks, and we still can do a lot better in that situation. And we've also learned that the biggest independent risk for severe outcomes with COVID is age. It's not Down syndrome. It's not immune suppression. It's age, more so than anything else. Age is the key predictor. If you take someone with Down syndrome who's 20 and you give them COVID, and you take someone without Down syndrome who is 60 and you give them COVID, the person without Down syndrome who's 60 is much more likely to go into the hospital and die from every statistic I've seen so far. Over and over and over again. The trump cards in every study are age and often where you got your COVID, in a long-term care facility being most important.
That's really helpful. And again, for our listeners to completely remember that these are both studies looking at adults with Down syndrome. These are not anything to do with the pediatric age population, which I know was a big concern when the headlines were coming out and saying people with Down syndrome are 8 times or 10 times more likely to die from COVID. This was looking at, again, a very specific population, as Dr. Nowalk has addressed with us, and also was not related to pediatrics, which again, we're not seeing the same rates in children as we're seeing in adults, as we talked about earlier in this podcast. Well, Dr. Nowalk, thank you so much again for your time. I love the fact that we have you as a resource to call upon and your knowledge to look upon whenever we're wondering about COVID, and especially COVID in looking in people with Down syndrome. So thank you again for joining us today.
If I can put one more piece of discussion on there, Kishore, as we close. First of all, thanks again for having me. This has been great to learn along with you about this. And I think these data, I hope that people can reflect on the fact that they're useful data. They do not yet tell us that people with Down syndrome are at dramatically increased risk. They tell us a lot of things we expected to see. If you continue to give any person with Down syndrome pneumonia, and if they're an adult, they're going to be in trouble, whether it's COVID or not, to be completely honest with you. And COVID is associated with some bad outcomes, not a surprise in our older people with Down syndrome. One of the other things I want to emphasize is that there is also the same racial twist to these data, in that in the UK, as well as in the United States, people of color are suffering at a much more disproportionate rate with poor outcomes than others. And it's sad for me to see this in the English data as well. So race and ethnicity, unfortunately, seem to play a role mostly in access to care. And that's something I hope that we all can keep in mind as we try to make sure everyone in all of our communities, Down syndrome and others, stays safe during this epidemic. And lastly, as always, mask. If 90% of the people mask 90% of the time, we'd be in a really different place.
Yeah, I agree. And thank you, Andy, for bringing that point about race and healthcare into the podcast as well. And I would direct our listeners to the series we did on race and healthcare and Down syndrome as well to get more information as to really boots on the ground. Why is it that we see these disparities even in patients and people with Down syndrome? So thanks, Andy, again for that. And for our listeners, thank you as always for sending in these requests. Believe me, I love it. And if there's requests related to COVID, I know where to go. And if there's requests on other things, we certainly have speakers that we have lined up for future podcasts that will be coming out here in the coming weeks. So keep listening. But until next time, bye-bye.